Hello and welcome to the Pediatric Network. My name is Mike Marinus. I am your chiropractor and host here for this research update on the Pediatric Network. So the reason that this has popped up in front of you is that you were part of the Pediatric Network, and the ethos that we have here is to keep you consistently updated with the latest evidence as it presents itself. So what we're going to be looking at today is a paper that came out. It is a systematic review of systematic reviews, which was published on the 11th of June, 2020. So pretty new stuff, depending on when you are when you are watching this. As it's coming out now, it's the 16th and 17th, I think. So pretty brand new, hot off the presses. So what is it all about? Let's have a look at the introduction here. So we're going to be looking at a research topic that covers the effectiveness and safety of conservative interventions for positional plagiocephaly and congenital muscular torticollis. And this is a synthesis of systematic reviews and guidance. So they've looked at systematic reviews and they've taken national guidelines and they've put them together and they've come out with their own systematic review on top of that. So the researchers we were looking at are Elwood, Draper Rohde, and Cairns. And this was published 2020, as we said now, in the Chiropractic and Manual Therapies Journal. So AIM, what were these researchers looking to investigate? Investigating congenital muscular torticollis and positional plagiocephaly, looking at the effectiveness and safety of manual therapy, repositioning therapy, and helmet therapy. Although helmet therapy, they only looked at positional plagiocephaly. And they used a systematic review of systematic reviews and national guidelines. So just to break down a systematic review for you, the idea of that is it is up with meta-analysis, or meta-analysis can be made of systematic reviews, and that is the highest level of evidence that you get. So what these authors have done is they've taken systematic reviews and they've reviewed those. And on top of it, they've taken national guidelines and they've squeezed them together to give us the latest on what that evidence is regarding effectiveness and safety of these three interventions when it comes to congenital muscular torticollis and positional plagiocephaly. So important, before we dive in, just to look at some of the definitions that they were using, because if we're not defined in our terms, we're not speaking about the same things. So first of all, when they talk about head repositioning, what we're talking about is it's performed by parents with the purpose of positioning that infant's head onto the non-flattened side. So this is for positional plagiocephaly. So these are children that have a flattening at the back of one side of the head, and parents are explained to how to reposition that child so that they do not put pressure on that flattened bone. And this also includes advice given on tummy time recommendations, because you'll know, if you've done our torticollis course, you'll know that tummy time is wonderful for congenital muscular torticollis and it's wonderful for positional plagiocephaly. Then we look at helmet therapy. What they're referring to here is orthotics, so the use of molding therapy, the use of these plastic helmets that are placed onto children with the aim of reshaping a deformed skull to a normal shape without restricting any cranial growth. And if you want to find out a little bit further on helmet therapy, hit up our Pediatric Network Facebook page. On there, you will find an interview with myself and Jovanka Terente. She is a registered cranial orthotist, and she really does a fantastic job of explaining how exactly helmet therapy is working with children. And then lastly, where they looked at manual therapy. So manual therapy, as we know, if you're a manual therapist watching this, that is a huge spectrum. But what they were talking about, and that's why it's really important in research like this that they define their terms. They were talking about chiropractic, osteopathy, physiotherapy, and physical therapists. And they centered on the techniques that were administered passively to the infant, either through articulation, so getting the joints to move, or soft tissue muscle stretching, so either getting the joints to move or aimed at getting that muscle tissue to move. Both of those looking to restore neck function and or soft tissue tension, release, and reduction. And it also includes practitioner-led stretching exercises, whether directly by practitioner or by practitioner-guided parent. So the idea there, either you as the practitioner have been performing the stretches or you have been guiding the parent into how to do these stretches. Now, importantly as well, when we're dealing with breaking down a research paper like we are now, we need to look at the method. I know it's wonderful just to dive in and look at the outcomes and the conclusions, but if you don't take a good look at the method, you might not know what kind of paper you're dealing with. So really, really important, we're going to cover that really quick. So it's a systematic review, as we said, of systematic reviews and clinical guidelines. And the included reviews, that reported systematic review methodology with more than one reviewer indicated in the review process. And that's so important because when you are looking at a systematic review, the one thing you want is it's not done by one person. The idea is to have almost like a group of people that are all qualified within that particular area to be able to put their heads together and say, yes, I think this, or no, I don't think that. The idea of that is to remove bias. So that's really nice. We've had 3 reviewers on here. We know that from the front, and they've stated here as well in their reviews that they're looking at, they didn't take systematic reviews that indicated they only had one reviewer. They only took papers with more than one reviewer. Also, the systematic reviews and guidelines have been published within the last 20 years, so they have to be relevant to what's happening. And very relevant here, that's very important here, because positional plagiocephaly, remember that the Back to Sleep campaign hit off in about 92, 94. So if we were looking before that, we might get some systematic reviews that had a little bit of skewed information, which is another type of bias. All right, and also looked at papers which were in English. Makes sense, we all speak English. It would be very difficult to review a paper not in English. Now, more definitions that we looked at here. So positional plagiocephaly, when they are talking about these outcomes and these interventions, they're talking about very specific things. So with positional plagiocephaly, they are talking about cranial asymmetry due to molding and not due to any other pathophysiological condition. So what could they be talking about? Craniosynostosis. So none of these children involved are craniosynostotic. In infants who are otherwise healthy and thriving, so there are no comorbidities that they could find in these children. Then a congenital muscular torticollis definition, we're looking at asymmetrical muscular tension in the neck, causing directional head preference from birth, but present in infants up to 1 year old who are otherwise healthy and thriving. So when we go through these outcomes, you're going to see that these are outcomes for these particular definitions of these particular problems. Okay, now also very important in the methodology, what kind of appraisal did they use? Because it's a systematic review. So what tools did they use to be able to work out that the reviews that they were using were actually worth their salt? So when it came to systematic reviews, they used something called AmStar2, which you're welcome to go and look up. It's a tool that's used to tell how good or how bad those systematic reviews are. And when it came to the clinical guidelines, they used a modified version of Agree-to framework. Both of those, because this paper is open access, so you're going to have access to it. So you're going to be able to read through the paper, and they have little appendices, and in those appendices are these. So if you want to get a little bit further into research yourself, to be able to understand how these things work and why, really, really cool, because this paper basically has it all for you. Now, let's have a look at how many studies they started with and how many studies they ended with, because that also, it tells a tale about where this research paper has been. So they started their first go-round and they first have a look on PubMed and all sorts of places, and you'll see when you have a look at the paper for yourself, because I really recommend that as well. Don't just take my word for what I'm saying. Go and have a look at the paper, because this one is available. So they started with 232 studies off their first look-around. 157 for plagiocephaly, 75 for muscular torticollis. Then they excluded 140, because that's how this process works, is that as you go through, you start to exclude them because they don't fit your very strict parameters that you've laid down. And those parameters you will find in that paper as well. So that left them with 92. Then they excluded another 78 when they read through those papers because they didn't quite fit the quality, or something else had gone wrong with those papers. Their final selection was 14 papers. So you can see that's what happens with these kind of reviews. You start off with hundreds of papers, and you literally end off, and anyone who has done this kind of work, you'll know what I'm talking about. I've done my fair share of going through these and starting literally with just desks full of papers and then eventually ending up with like 14. like we did here. So 10 papers were left for positional plagiocephaly and 10 were there for congenital muscular torticollis. All right, now we know what they were looking at and we know what they were trying to find and how they were going about finding it. Now let's have a look at their actual findings. So what were the outcomes of this paper? So first of all, the outcomes for positional plagiocephaly. So the first, results reported that repositioning therapy was favorable when compared with usual care and unfavorable when compared with manual therapy or helmet. So you can see there's a hierarchy that's starting to be developed here. And these studies, so you can kind of take these to the bank because these studies were graded moderate to high level of evidence. Then manual therapy produced favorable outcomes compared to repositioning therapy. So now we can see the hierarchy builds even further, or standard care. But it was inconclusive findings when it compared manual therapy to helmet therapy. And the quality of the studies here varied. So that first one you can kind of take to the bank. The second one you have to be a little bit circumspect with that finding, simply because the quality of the papers went kind of moderate and low, and they kind of went all over the place. So you have to be a little bit circumspect with what you find there. Now let's have a look at their findings on congenital muscular torticollis. So one of the reviews that they looked at reported favorable results after 3 weeks of manual therapy. And what they were talking about with this particular manual therapy was practitioner-led stretching. And the level of evidence was graded as moderate. So quite nice, actually, quite a good rating. If you go and have a look at what moderate actually says in the literature, moderate is actually not bad at all. The other two reviews each reviewed the same pilot study. So the other two reviews they looked at were both zoned in on one study themselves, where both groups received pediatric physiotherapy, and the intervention group also received additional spinal mobilization. So you had two groups, both of them getting physio, but the one also getting mobilization therapy on top. Interestingly, that pilot study showed that there was no significant difference if you added the mobilization on top or you didn't. Interestingly, though, and this is why you need systematic reviews, is that both of these reviews they looked at that one pilot study, both of those weighed the evidence they were looking at differently. So it does happen. So one of the reviews looked at the evidence as very low, and the other one looked at it as moderate. So again, as I say, it's interesting to get this information, but please, please, please always take it with a pinch of salt. Now, that was the systematic reviews that they looked at, but remember from the beginning, they looked at national and clinical guidelines as well. So what did these guidelines tell us? Because these are heavy-duty pieces of machinery, the guidelines, so it's good to be able to take from them the information that they give. So the positional plagiocephaly guidelines they looked at, there was one guideline that met their standards, and it was the Congress of Neurological Surgeons Task Force, which was done in 2016. And the cool thing as well is it was based on 3 systematic reviews, which themselves were all published in 2016. So a lot of really fresh information that the Surgeons Task Force were using when they put together the guidelines for positional plagiocephaly. So what did they recommend? What did they say that we should do? So they said physical therapy and repositioning are your first-line treatments, then followed by helmet therapy as a second-line treatment for infants with moderate to severe and persistent asymmetry of that head. They also recommended physical therapy above positioning pillows due to the risk of SIDS with that pillow. And we're going to talk about that because that's the whole idea. We really don't want anything else in the bed with the child because it might change their positioning or they might roll onto it or something like that. So even though, as you'll see when we look at the discussion, there's quite a bit of good evidence around the pillow because there is that added risk of a potential sudden infant death syndrome, we don't put it in the same category or the same group. Okay, then if you've done the Torticollis course, you will be super familiar with Kaplan et al. In 2018 because these are the guidelines that we used to put together a lot of that information in the Torticollis course. So what did they say? First-line treatment is similar for positional plagiocephaly and for congenital muscular torticollis and if you've done the plagiocephaly course, you will know that there is a high amount of correlation between these two issues. They said parent education, support, positioning and tummy time, physical therapy, including passive articulation and stretching. All right, so let's jump now into the discussion. Okay, so in the discussion in this paper, they talked about positional plagiocephaly, and they said that the results indicate repositioning therapy has a moderate to high quality evidence. And there's a mix of favorable and inconclusive findings here, but it is a moderate to high quality evidence. When it comes to repositioning therapy, nice, take it to the bank, use it with your parents. Manual therapy interventions had moderate to high quality evidence showing favorable outcomes compared with repositioning therapy and positioning pillows, but equivocal low evidence findings when compared with standard care and compared with helmets. Now, looking at helmets, helmet therapy was favorable for head shape change, but the quality of the studies was low, quite interestingly, indicating that there is a certain amount of uncertainty around these findings. And effectiveness, when you looked at a helmet use versus manual therapy, was inconclusive. Now, the discussion then turned to looking at congenital muscular torticollis outcomes, and they looked at manual therapy of practitioner-led stretching. Remember, we talked about that before. That's where the practitioner actually goes through and leads the stretching of the child's neck. That had moderate favorable evidence for increasing range of motion and low-quality, inconclusive evidence to support spinal mobilization in addition to physiotherapy. So remember, we have talked about that paper, and we've said how and why that was their finding. But, as we said then, and as we're going to say now, there is caution that is required when you're interpreting this evidence for manual therapy for CMT, because it only relies on one underpowered pilot study. And underpowered, what do they mean? They mean that's not the outcome it was designed to be able to find. So it found it, but it's underpowered because it wasn't geared in that direction. It was an underpowered pilot study with methods that were inappropriate to assess effectiveness. So basically, we're still on the lookout for a little bit more information to be able to go, yes, let's take it to the bank. And for CMT, it's a mixed and confusing batch of evidence, and it's compounded with the fact that there's poor standardization of measurement criteria, and that's not just for torticollis, that is for positional plagiocephaly as well. And you'll see when we get our positional plagiocephaly course up and running, you're going to see the ways to measure. There are many, and many of them are just not based. They have poor interrelator reliability, poor intra-relator reliability, but we'll see as we get further down that road. Okay, so what else did they say in the discussion? So, first-line treatment from the guidance for both positional plagiocephaly and congenital muscular torticollis was parent education and support. So important. So you'll see in our torticollis course, we talk about this all the time. We talk about what to educate, how to educate, what to tell, and then how to support those parents going through it. Also, positioning. Tell them how to position their children. Tummy time, so important. Again, I hammer it again in our torticollis course. We talk about the amount of time or the amount of information parents are given about sleeping their children on their back, but then the limited amount of information they're given about spending time on the tummy, and then even further limited information on how to actually do it. So it's really important as a practitioner in this space to know that kind of stuff so that you can give that over to the parents. And of course, the last line of that first line treatment is physical therapy. Then, parent education and support is centered on reassurance. We want to reassure that in the majority of cases, now I want you to be a little bit careful about the sentence though. In the majority of cases, positional preference and head shape is the big word there, resolve over time and may be helped with repositioning and physical therapy. The problem is the way that the authors kind of put that across, and even the authors say the way that is said, it kind of leaves arguments for treatment as very limited because you're kind of saying, well, it'll come right. I refer you back because, I want you to speak to the experts here. I refer you back to go and listen to Jovanka Terente talk about this in particular in our talk on the Pediatric Network Facebook page. She explains so well why this is potentially not the case, and because treatment has, because there are so many outcomes that the treatment is designed to be able to fix up, and it's not just aesthetics. A lot of the time it's cognitive stuff, and they do go into it in this paper because they say in severe and moderate cranial asymmetry, There are later cognitive and academic outcomes, and one must see these things as a potential marker for developmental risk. So it might be one part of the paper where I think they've just erred on the side of caution because of what's out there, and good to you, because you're authors of papers, and the whole idea is not to be focused in one direction. It's to be as open to what the actual information that we have at hand says. I just also want to throw in a little bit of an authority, of a cranial orthotis there, just to be able to balance out that information that you're getting. But that's the whole point of the pediatric network. It's not to be focused in one direction. It's to look at, in as balanced way as possible as we can, at as much of the information that is there to be able to present itself to us. Okay, so my diatribe over. Let's move back in. So repositioning, and this includes tummy time and stretching regimes, they just make sense, right? They make intuitive sense. When you consider the mechanistic explanatory model for why we would treat this kind of problem, you want to get them in the opposite direction, stretch the muscles, take pressure off the back of the head. It makes sense to do these things. Keep in mind, though, when you're working with the parent, there's going to be a high placebo element inside there. Why? Because the parent's involved, because we're doing a lot of practitioner-led but parent-based stretching, and the parents are doing the repositioning. So the parents really are the hero inside this, and we literally are just there as the guides to be able to guide them through this, which is perfect, because that's exactly where we should be. And because they play this active role in resolving the issue, there is going to be a high placebo. But remember that parent, they're still going to need advice from you, and they're still going to need guidance, and they're still going to need support. And that support doesn't have to come from one profession, which is the best thing. It doesn't matter what profession you're in. The evidence is the evidence is the evidence. And if you're in a position to give the latest evidence-based information, you have got to do that, which is why being part of a network like ours is so cool, because we just keep feeding you what that high-level information is right now at the moment. Okay, another diatribe. Sorry about that. Okay, so the clinician or therapist that is delivering advice, guidance, and support to parents does not have to be limited to one profession. We talked about that, especially because this allows for more access and support and advice and care. So it shouldn't matter where they go or where they are on their journey. They should be getting the evidence-based advice from one of us somewhere out there. Okay. Now, this suggested issue with the pillows that we talked about before, remember we said that there was quite a good level. So here we see moderate to favorable beneficial effects on head shape and symmetry when you use these positioning pillows. The problem is, because there is this potential risk for SIDS, when it comes to evidence, that it does not outweigh SIDS. So the fact that it would change it and there's moderate to favorable evidence, you can do it another way without having that pillow in there. So that is what the evidence says currently. Okay, and then that Congress of Neurological Surgeons guidance recommended that manual therapy and repositioning be used rather than the positioning pillows. So if you get a parent that asks you what your advice is, the evidence-based standpoint is that the latest guidelines we have, which are from 2016, which are from some quite high-level people that have put their information on top of the empirical evidence, they say manual therapy and repositioning rather used than positioning pillows. Now, let's spend a little bit of time on adverse events. We never like to do that, but we have to because we're looking at the evidence, so it's very, very important that we do. So, no adverse serious events were reported in any of the randomized controlled trials here that were reviewed by the systematic reviews that then got reviewed by our systematic review that we're looking at. 2 of the studies, however, inside that review did take a look at other adverse events that had happened in other studies and other case reports. So very important that nothing actually happened in the reports we're looking at. These studies were then talking about other studies that they had read. So Driehuis et al., 2019, had reported temporary quadriplegia following treatment of a 4-month-old, so that is out there in the literature. There was another case of a death of a 3-month-old girl. And while both of these, and this is a very important sentence to have a look at, while both of these adverse events were associated with cervical spine manipulation for congenital muscular torticollis in one of the studies, the other study associated the death with administration of the Voiter technique, which is a physiotherapy technique. So It's difficult because you have to remember that sometimes we're just reporting things that are from here and there, and the information does get a bit messed around. Okay, so important just to know. However, both of those do exist in literature, although they may be a little higgledy-piggledy. So what did this review say? It said that adverse events, the causality between manipulation and the adverse events are inconclusive. That's where the evidence stands currently. Minor adverse events were seen with helmet use, so those are things like skin irritation and rashes. And obviously that kind of thing might affect tolerance of these children. It might make it a little difficult for them to be able to use the helmets, and they might want them off and that kind of thing, and the pulling on and off might add to the skin irritation and what have you. But it does, with all the evidence together, it seems sensible to consider conservative treatment first, unless otherwise indicated. Okay, now we get to what we've been looking for, the conclusion of this systematic review of systematic reviews. So, what do we say? So, and this is verbatim this is the conclusion from the paper. I haven't added anything, I've not subtracted anything, and you can go and grab the paper. I really suggest you do. Go and get it and have a look at it for yourself. So, from the paper, the conclusion states, manual therapy from positional plagiocephaly showed favorable outcomes when compared with repositioning therapy, but equivocal low-level evidence when compared with helmet therapy. The results for CMT showed that manual therapy in the form of practitioner-led stretching had moderate favorable evidence for increasing range of motion, but this evidence only relies on that one underpowered pilot study, and more well-powered effectiveness and efficacy studies are desperately needed. Distinguishing between superiority of treatments is difficult due to the lack of standardization of measurement systems, so we talked about that as well. The variety of outcomes and limited high-quality studies, so a lot of stuff that gets in our way of being able to say what is better treatment-wise. So there's still a need to have an accepted classification system for diagnosing and prescribing these grades of PP and CMT, because it's that way that then we get to fully investigate and then we get to fully work out, is a therapy actually warranted? And what is the chance of that therapy actually having a meaningful change to that child? And the type of treatment appropriate for the infants and the duration and the dose of treatment is yet to be clearly determined. And you will see that if you do our Torticollis course, or if you have already done our Torticollis course, you'll know that the literature goes all over the place. There's one point where they literally say 100 of them are better than 50 of them a day. That's where the evidence stands. Okay, and then to finish off our lecture here, overall physical therapy such as stretches and/or exercise, repositioning, tummy time may benefit some infants. Education, guidance, and support is likely to reassure and to help parents. So use that. Make sure that you use it. Advice and guidance can be given by a variety of healthcare professionals, but clearly clinical training is necessary to ascertain whether these infants are healthy and thriving and no underlying pathologies, because you do not want to miss anything when you deal with kids before the conservative approach or the treatments are recommended. So I thank you very much for coming and joining us here on this quick little research update to the effectiveness and safety of conservative interventions for positional plagio and congenital muscular torticollis, a synthesis of systematic reviews and guidance.